Hi everyone, a blessed day to all of you. Praying that all of you are safe and doing well in your study. So this presentation is a continuation of our topic about the care of patients with problems in immune system. Before we proceed with our discussion, let me first read to you this disclaimer slide. Please note, no copyright infringement is intended, and I do not own or claim any images, designs, and any of the original information stated and used in this video. And this is used for educational purposes only. If any content owners would like to dispute this, I will not hesitate to immediately remove the said content. If you happen to find your art or images in the video, please let me know and I will be glad to credit you. Here is my email, obri.dairit@cjhc.edu.ph. So as mentioned, this presentation is a continuation about the topic on the care of patients with problems in immune system. So in this particular presentation, we will talk about acquired immune deficiency, or this is also known as HIV, or human immunodeficiency virus, which is a virus that attacks the human body, or especially the immune system. And if it is not treated, this will lead to AIDS. So this is the outline of this presentation. So the following will be discussed about the pathophysiology of AIDS, the assessment and diagnostic findings, the clinical manifestations, and most importantly, the medical and nursing management. So let's talk about AIDS, or acquired immune deficiency syndrome. So AIDS can be acquired due to medical treatment or infections from agents such as the human immune deficiency virus, or known as HIV. So advances have been made in treating HIV infections and acquired immune deficiency syndrome. However, AIDS remains a critical public health issue in communities across the country and around the world. So prevention, early detection, and ongoing treatment remain important aspects of care for persons living with HIV infections or AIDS. So the causative agent of human immunodeficiency virus includes HIV-1 or type 1 and HIV-2 or type 2. So the inflammation and breaks in the skin or the mucosa result in the increased probability that an HIV exposure will lead to infection. The human immune deficiency virus type 1 is transmitted in body fluids such as your blood, seminal fluid, vaginal secretions, amniotic fluid, and even breast milk that contain the infected cells. So higher amounts of HIV and infected cells in the body fluid are associated with the probability that the exposure will result in infection. So the mother-to-child transmission of HIV-1 may occur in the utero at the time of delivery or through breastfeeding, but most perinatal infections are thought to occur after exposure during delivery. So you have to remember that HIV is not transmitted through casual contact. So these are the risk factors. The most common mode of transmission is through sexual contact. And the ways to prevent, according to DOH, the most or the completely safe is abstinence is of course to avoid um, having sex with, particularly with a person infected with HIV. Very safe sexual impression or non-insertive activities, for example, just kissing, hugging, or mutual masturbation. Probably safe by if you are using, of course, you have to use condom, although it's not 100% safe. So the general guidelines is, of course, to only have one sexual partner. So you have to be loyal. You have to have a long-term relationship with one partner only. And for blood products, this is the second most common mode of transmission. So blood and blood products can transmit HIV to recipients. However, the risk associated with transfusion has been virtually eliminated as a result of voluntary self-referral, completion of a detailed health history, extensive testing, heat treatment of clotting factor concentrates, and more effective virus inactivation methods. So the donated blood is tested for antibodies to HIV-1 or type 1 and human immunodeficiency virus type 2. Now let's talk about the pathophysiology of HIV. So we know that HIV is an infectious disease. Therefore, it is important to understand how HIV-1 integrates itself into a person's immune system and how the immune response plays a pivotal role in the course of HIV disease. This knowledge is essential for understanding medication therapy and vaccine development. Viruses are intracellular parasites that has a spherical shape, and it is the subfamily of lentiviruses and is retrovirus because it carries its genetic material in the form of ribonucleic acid or RNA rather than deoxyribonucleic acid or DNA. So it has a mushroom-like projections. We have GP120, which is a molecule of HIV-1, which is a glycoprotein that is part of the outer layer of the virus. It presents itself as viral membrane spikes consisting of three molecules of GP120 that is linked together and anchored to the membrane by GP41 proteins. These proteins allows the HIV to recognize the CD4 markers outside the helper T cells. So like many cell surface receptors or markers, CD4 is a member of the immunoglobulin superfamily. It has four immunoglobulin domains, G1 to D4. So it binds at the surface of the helper T cell and it contains a genetic material, so as mentioned, RNA, and it has three enzymes such as reverse transcriptase and integrase and protease. Two genetically different but closely related forms of HIV, such as the HIV type 1 and HIV type 2, have been identified. The course illness is slower when the infection is caused by HIV-2, which seems to be more common in Western Africa compared to HIV type 1, which is more common in other regions of the globe. So blood tests may be used to screen for both forms of HIV. So this figure shows the figure A shows a structure of HIV-1 virus, the virus surrounded by a lipid envelopes. So as you can see. So this is the lipid membrane and the protruding glycoproteins. On the other hand, the figure B shows the life cycle of the HIV-1. So as you can see in this figure, HIV consists of a viral core consisting of protruding glycoproteins. All viruses target specific cells. HIV targets cells with CD4 plus receptors, which are expressed on the surface of T lymphocytes, monocytes, dendritic cells, and brain microglia. The mature T cells or T lymphocytes are composed of two major subpopulations that are defined by cell surface receptors of CD4 plus or CD8 plus. Approximately two-thirds of peripheral blood T cells are CD4 plus, and approximately one-third are CD8 plus. So most people have about 700 to 1,000 CD4 plus cells per cubic millimeter, but a level as low as 500 cells per cubic millimeter can still be considered within normal limits. So during stage 0, which is also known as acute or recent infection, so most varieties of HIV-1 use the chemokine cell receptor molecules or the CCR5 or R5 virus for entry to T cells, in addition to CD4 plus receptor, which suggests that the R5 variant is preferred to a different variant, such as your CXCR4. But the preferred co-receptor can shift over the course of infection. So let's talk about the HIV life cycle. So it actually consists of about 9 steps. So the first one is attachment or binding. So during this first step, the GP120 or the glycoproteins 120 and GP41 glycoproteins of HIV bind with the host, an infected CD4 plus receptor and chemokine co-receptors, usually CCR5, which results in fusion of HIV with the CD4 plus T cell membrane. So, when we say binding, this means that the virus binds or attaches itself to molecules on the surface of the CD4 cells. Mainly, it is your GP120 and GP41 that binds with the CD4 cells. The second step is encoding or fusion. So after the HIV attaches itself to a CD4 cell, the HIV viral envelope fuses with the CD4 membrane, and only the contents of HIV's viral core are emptied into the CD4 plus T cell. So the fusion allows the HIV to enter the CD4 cells, and once inside the CD4 cell, the virus releases HIV RNA and HIV enzymes. Okay, there are 2 single strands of viral RNA and 3 viral enzymes, such as the reverse transcriptase, integrase, and protease. The third step is the DNA synthesis. The HIV changes its genetic material from RNA to DNA through action of reverse transcriptase, resulting in double-stranded DNA that carries instruction for viral replication. And the fourth stage or step is the integration. The new viral DNA enters the nucleus of the CD4 T cell and through action of the integrase is blended with the DNA of the CD4 plus T cell, resulting in permanent lifelong infection. Prior to this, the uninfected person has been only exposed to not infected with HIV. With this step, HIV infection is now permanent. The fifth stage is the transcription, or known as reverse transcription. Once converted, it allows the HIV to enter the cell nucleus and combine with the cell's genetic materials. So once this happens, the DNA becomes double-stranded that carries instruction for viral replication, or it builds new viruses. The sixth step is translation. So during translation or transcription, this is actually the stage of replication, wherein the virus uses the machinery of the CD4 cells to create long chains of HIV proteins. Then, the protein chains are the building blocks for more HIV. So, mas dumadami yung construction of new viruses. And the eighth step is the cleavage. The mRNA creates chains of new proteins and enzymes or polyproteins that contain the components needed in the construction of new viruses. So, embodying the new proteins and viral RNA migrate to the membrane of the infected CD4 plus T cell, exit from the cell, and the start of process all over. So this figure shows the life cycle of HIV that starts from binding, so as you can see the virus, and then fusion, so it enters the CD4 cell, and then reverse transcription, and then integration, replication, assembly, and then bonding. So this just consists of 7 steps, unlike the life cycle discussed in SUDARTS, which consists of 9 steps. So I hope you won't be confused because I could not find an image or an example figure that consists of 9 steps. So this figure is just another image or a closer image of the virus. So this one, the mushroom like is the GP120 and this is the GP41. So just for you to see it closer. There are 3 stages of HIV disease. The first stage is known as the primary infection stage, where there is an acute HIV infection or acute HIV syndrome. This usually occurs between 4 to 7 weeks. So this starts from infection with HIV to the development of HIV-specific antibodies. This is also known as the window period, which is part of stage 0. So there would be a minimum of 3 weeks and a maximum of 6-month time wherein ELISA test will reveal a negative result. So acute HIV infection is the interval between the appearance of detectable HIV RNA and the first detection of antibodies. So its duration depends on the design of the antibody immunoassay and the sensitivity of immunoassay during seroconversion, or the antibodies could develop it in 2 to 3 weeks. So initially, there is a period during which those who are HIV positive test negative on the HIV antibody blood test, although they are infected and highly infectious because their viral loads are very high. About 40% to 80% of the patients develop clinical symptoms of a non-specific viral illness that includes lymphadenopathy, fatigue, malaise, joint pain that last about 1 to 3 weeks or the viral set point. So after 2 to 3 weeks, the antibodies to the glycoproteins of the HIV envelope can be detected in the sera of people infected with HIV. But most of these antibodies lack the ability to totally control the virus. By the time neutralizing antibodies can be detected, or known as stage 1, HIV-1 is firmly established in the host. The primary or acute infection is characterized by high levels of viral replication, widespread dissemination of HIV throughout the body, and destructions of CD4 T cells, which leads to a dramatic drops in the CD4 T cell counts. So we know that the normal count is between 500 to 1,500 cells per cubic millimeters of blood. The host respond to the HIV infection through a CD4 T cells response that causes other immune cells such as CD8 plus lymphocytes to increase their killing of infected virus protruding cells. So the body produces antibody molecules in the effort to contain the free HIV particles outside the cells and assist in their removal. During this stage, the virus is widely disseminated in the lymphoid tissue, and a latent reservoir with a resting memory CD4 plus T cells is created. So after the viral set point is reached, a chronic stage persists in which the immune system cannot eliminate the virus despite its best effort. So the set points varies greatly from patient to patient and dictates the subsequent rate of decreased progression. So the second stage is known as the HIV asymptomatic. This stage 2 occurs when the CD4 plus T lymphocyte cells are between 200 and 499. So the viral set point has been reached, and then the viral replication reaches a lower but steady state, and the patient may have 8 to 10 years asymptomatic because the CD4 count is high. That can last longer if the patient have strong immune system and have a healthy lifestyle. The criteria of the stage includes symptomatic HIV infection, persistent generalized lymphadenopathy, and primary HIV infection with accompanying illness or history of acute HIV infection. So stage 3 is known as surveillance severity stage. This happens or occurs when the CD4 T lymphocyte cells drops below 200 cells per cubic millimeters of blood. And at this point, the person is considered to have AIDS for surveillance of severity stage. It cannot be reclassified into a less severe stage even if the patient has CD4 plus T lymphocytes increase, which often occurs when a person receives a treatment known as antiretroviral therapy. So The stage 3 diagnosis as implications for services, example, disability benefits, housing, and food stamps. Of course, this is only applicable in the United States, not in the Philippines. Okay, maybe disability benefits, but no housing and food stamps, because this is not the program in our country. So moving on to CDC category C of HIV. So if the category C before but has a high CD4 count, this can be considered as managed category C, or AIDS. There would be two major and one minor. So when we say major, these are the major symptoms, signs and symptoms, such as fever for 1 month or more and chronic diarrhea for 1 month. And there would be 10% weight loss. And there will be presence of one minor sign and symptoms. For example, persistent cough for a month, or persistent generalized lymphadenopathy, or generalized pruritic dermatitis, or oropharyngeal candidiasis, or could be recurrent H. zoster and progressive disseminated herpes simplex. So any two major sign and symptoms and one minor sign and symptoms, this can be considered a CDC category C. For the assessment and diagnostic findings, there are three types of diagnostic findings, such as the antibody test, number 2, the antigen or antibody test, and 3, the nucleic acid or RNA test. During the first stage of HIV infection, the patient may be asymptomatic or may exhibit various signs and symptoms, such as fatigue or skin rash. Patients who are in later stage or stages of HIV infection may have a variety of symptoms related to their immunosuppressed state. The staging system requires laboratory evidence of HIV infection in order to diagnose HIV or AIDS. So, HIV test, several screening tests are used to diagnose HIV infection, and others are used to determine the stage and the severity of the infection. So, a serologic testing algorithm for HIV or recent HIV seroconversion or STARS analyze HIV positive blood samples to determine whether an HIV infection is recent or has been ongoing. So recommended routine screening of all persons aged 15 to 65 years, as well as screening of younger or older persons who are at risk. So there are again three types of diagnostic tests. So antibody tests. So HIV antibodies are usually produced after 3 to 12 weeks of infection. So antibodies positive patient is infected with the virus. This means that the HIV is active in the body and the patient can transmit the virus to others through body fluids, such as during sexual intercourse, or needle prick, or during delivery. Okay, antibodies negative, meaning not infected with HIV, or the body has not produced antibodies yet, and the window period is between 3 weeks to 6 months. So you can have ELISA test wherein the antibodies are detected, and then the Western blot assay, and the test confirm the ELISA test. And then CD4 count or viral load test, it measures the RNA or the HIV RNA in the plasma. And then the CD4 count, we know that the normal count is between 500 to 1,500 cells per cubic millimeter of blood. Less than 200 cells per cubic millimeter of blood could be considered as stage 3 infection AIDS. So CD4 count vary from day to day, so it is usually checked every 3 to 6 months. Okay. So again, the viral load is the amount of HIV in the sample of your blood. So there will be no normal viral load value. This table shows the common blood test used for screening HIV. So this is adapted from Centers for Disease Control and Prevention. So we have HIV-1 or HIV-2 immunoassay to test for both HIV-1 and the antibodies. And we have HIV or 1 or HIV-2 antigen or antibody combination immunoassay. That is to test for both antibody and virus for both HIV-1 and HIV-2. And we have HIV-1 differentiation assay to differentiate HIV-1 from HIV-2. And HIV-1 nucleic acid amplification test. This is to test directly for the virus. And HIV-1 P24 antigen. This is again to test directly for the virus. So when the result of the HIV antibody test is received, it is carefully explained to the patient in private. So you have to remember that, future nurses. All test results are, of course, confidential. So you have to consider the patient's psychological response to a positive test result that may include feelings of panic, depression, and hopelessness. So some newer antigen or antibody laboratory tests can sometimes find HIV as soon as 3 weeks after exposure to the virus. So no antigen or antibody or RNA tests are available for oral fluids. So follow-up testing is performed if the initial test result is positive to ensure a correct diagnosis. So these tests include antibody differentiation tests to distinguish HIV-1 from antibodies, and HIV-1 nucleic acid test to look for the virus RNA directly. Moving on to the interpretation of negative results. This means that the antibodies to HIV are not present in the blood at this time, which can mean that the patient has not been infected with HIV, or if infected, the body has not yet produced antibodies. So this means this is still in stage 0. However, the patient should continue taking precautions because the test result does not mean that the patient is again immune to the virus, nor does it mean that the patient is not infected. It means that the body, again, may not have produced antibodies yet. So if the viral test used, a negative result is more consistent with the conclusion that the patient is uninfected. So now for medication therapy, there are 4 classes. The first one is the fusion or entry inhibitors. These are antiretroviral drugs that works outside of the host CD4 cells to prevent HIV from fusing. If the HIV cannot penetrate the host cell membrane and infect the cell, HIV cannot replicate in the host cell. While the reversed transcriptase inhibitors, or the second class, the new DNA cannot be built correctly. In turn, genetic material cannot be incorporated into the healthy genetic material of the cell and prevents the cell from producing new viruses. As is the integrase inhibitor, which are designed to block the function integrase. Integrase is a viral enzyme that inserts the viral genome into the DNA of the host. And the fourth class is the protease inhibitor that prevents viral replication. So for anti-HIV drugs, we have ART or antiretroviral therapy. The goal is to suppress HIV replication to a level below which drug-resistant mutations do not emerge, and those are the related goals. Number one is to reduce HIV-associated morbidity and prolong the duration and quality of survival. Number two is to restore and preserve immunologic function. Three is to maximally and durably suppress plasma HIV viral load. And fourth is to prevent HIV transmission. So we have hard or highly active antiretroviral therapy such as your fusion and entry inhibitor. For that, we have enfovertide for T20, and then NNRTI, we have nevirapine or your Veramune and efavirenz or Sustiva. This may have side effects or adverse effect in the CNS, or the patient may have CNS symptoms. For the NRTI, this is the mainstay treatment. It prevents dying of helper T cells and prevents reverse transcriptase. We have pseudovidin, didanosine, and this didanosine may have adverse effect. It can lead to pancreatitis, peripheral neuropathy, and lactic acidosis. We also have protease inhibitor or Navir, such as your Indinavir or Crixivan, and this type of drugs may lead to or may cause nephrolithiasis, blurred vision, metallic taste. Saquinavir, also an example of your protease inhibitor, Melphinavir or Verisip. This may cause hyperglycemia, so you have to be very careful of the adverse reaction or of the side effects of such drugs. Those anti-HIV drugs or the antiretroviral therapy may cause the following general side effects, such as myelosuppression, wherein there will be a decrease in RBC, WBC, and platelet counts. May also cause hepatotoxic. There will be increase or decrease in the SGPT or SGOT, and can cause gastrointestinal toxicity such as nausea, vomiting, diarrhea. This can happen upon taking with food. Hypersensitivity reactions may also happen or occur, such as rashes, itchiness, and urticaria. So if the patient has or is taking antiretroviral drugs, you have to instruct the patient to avoid high fat because this can block or the fats block antiretroviral drugs. Moving on to the clinical manifestations of the patient with HIV. So patients with HIV may experience a number of symptoms related to the disease, side effects of treatment, and other comorbidities. That includes the following. The patient may have respiratory manifestations, gastrointestinal manifestation, oncologic, neurologic, depressive, and even integumentary manifestation. Let's discuss each of these clinical manifestations per system. So for the clinical manifestations in the respiratory system, the patient may have pneumocystis pneumonia or PCP, which is caused by a P. cerevisiae, or formerly known as P. carinii. So subacute onset of progressive dyspnea, fever, non-productive cough, and chest discomfort that worsens within days to weeks may be experienced by the patients with pneumonitis pneumonia. Also, the patient may have Mycobacterium avium complex, which is a common opportunistic infection that typically occurs in the patient with CD4 plus T lymphocyte counts less than 50 cells per cubic millimeter in blood. Or the patient may have tuberculosis or TB disease that can occur at any CD4 plus T lymphocyte count, although the risk increases with progressive immune deficiency. Those patients with a latent TB with HIV infection is treated with isoniazid supplemented with pyridoxine or aminoxine to prevent peripheral neuropathy for about 9 months, since it has proven efficacy, good tolerability, and infrequent severe toxicity. So for patients with pneumocystis pneumonia, particularly those patients with stage 3 HIV infection, they should receive a chemoprophylaxis such as trimethoprim or sulfamethoxazole for patients with CD4 plus counts less than 200 cells per cubic millimeter or a history of oropharyngeal candidiasis. Adjunctive corticosteroids prednisone are indicated as early as possible, preferentially within 72 hours after starting the specific PCP therapy. So the treatment duration is usually 21 days. So rates of adverse reaction to TMPSMs are high, including rash, fever, leukopenia, hepatitis, and hyperkalemia. So for patients with Mycobacterium avium complex, the initial treatment consists of 2 or more antimycobacterial drugs to prevent or delay the emergence of resistance. So the drug of choice includes clarithromycin or Bioxin, which is the preferred first agent. However, azithromycin or Zithromax can be substituted for clarithromycin when the drug interactions or intolerance to clarithromycin preclude its use. Ethambutol is the second recommended drug. For patients with cryptococcal meningitis, the treatment includes 3 phases such as induction, consolidation, and maintenance therapy. For induction therapy, this includes amphotericin B or IV lipid formulation plus fluconazole or diflucan for 2 weeks, And then consolidation therapy includes oral fluconazole daily, which should continue for at least 8 weeks. So the adverse effects includes anaphylaxis, kidney and hepatic impairment, electrolyte imbalances, anemia, fever, and severe chills. Therefore, as a nurse, you must monitor your patient closely. So, for patients with cytomegalovirus retinitis, which is the leading cause of blindness in patients with HIV, so they must be given oral valganciclovir or Valsite, IV ganciclovir or Cytovin, IV ganciclovir followed by oral valganciclovir or IV foscarnet or foscovir, IV cidofovir, Vestide, and a ganciclovir intraocular implant coupled with valganciclovir. So the adverse reaction may include bone marrow suppression, neutropenia, hepatitis, renal toxicity, seizures, and etc. So the gastrointestinal manifestations of HIV infection and AIDS includes loss of appetite, nausea, vomiting, oral and esophageal candidiasis, and chronic diarrhea, as well as HIV wasting syndrome. So the gastrointestinal symptoms may be related to the direct inflammatory effect of HIV on the cells lining in the intestines. Some of the enteric pathogens that occur most frequently identified by stool cultures or intestinal biopsy are Cryptosporidium monis, Salmonella species, Isospora belli, and etc. So the therapy for chronic severe diarrhea includes octreotide acetate or sandostatin, which is a synthetic analog of somatostatin. So, somatostatin inhibits many physiologic functions, including gastrointestinal motility and intestinal secretions of water and electrolytes. So, patients with HIV or AIDS are at greater risk of developing certain cancers, such as Kaposi sarcoma, lymphoma, and invasive cervical cancer. So, this figure shows lesions of the AIDS-related Kaposi sarcoma, whereas some patients may have lesions that remain flat, others experience extensively disseminated raised lesions with edema, as you can see in this picture. So, for Kaposi sarcoma, it involves the epithelial layer of blood and lymphatic vessels. So, AIDS-related Kaposi sarcoma exhibits a variable and aggressive course, ranging from localized cutaneous lesions to disseminated disease involving multiple organ systems. So, it is caused by human herpes virus 8 or HHV8 virus that affects 8 times more men than women. This can be spread through sexual contact. The ulcerative lesions of Kaposi sarcoma disrupt the skin integrity and can increase discomfort and susceptibility to infection. The most common sites of visceral involvement are the lymph nodes, gastrointestinal tract, and the lungs. So for Kaposi sarcoma, local therapy, radiation therapy, chemotherapy, and biologic therapy can be helpful for patients with Kaposi sarcoma. And for lymphoma, there is no standard treatment for AIDS-related peripheral or systemic lymphoma. The treatment plan is adjusted for each patient and usually includes one or more combination of chemotherapy, high-dose chemotherapy, and stem cell transplant. There are many ongoing clinical trials using monoclonal antibodies and different treatment combination that the patients with AIDS-related lymphoma may be eligible to enter. So for AIDS-related lymphoma, this includes both Hodgkin lymphoma and non-Hodgkin lymphoma, and this is usually aggressive. There are three types. These are the diffuse large B-cell, uh, B-cell immunoblastic, and small non-cleaved cell lymphoma. So non-Hodgkin lymphoma is actually more common. So the symptoms includes weight loss, night sweats, fever. So the complete blood count might be abnormal and the biopsy will confirm the diagnosis. So HIV-related brain changes have profound effects on cognition, including motor function, executive function, attention, visual memory, and visospatial function. So neurologic dysfunction usually results from direct effects of HIV on the nervous system tissue. These opportunistic infections, primary or metastatic neoplasm, cerebrovascular changes, metabolic encephalitis, or complications are secondary to therapy. So the patient may have again peripheral neuropathy, HIV encephalopathy, or formerly known or referred as AIDS dementia complex, or Cryptococcus neoformans and progressive multifocal leukoencephalopathy. So the immune system responds to HIV infection in the central nervous system that includes inflammation, atrophy, demyelination, uh, degeneration, and necrosis that again causes the following signs and symptoms. Depression and apathy are neuropsychiatric complications of HIV infection. Estimates suggest that the prevalence of current depression is between 30% and 40% in persons with HIV or AIDS. Apathy, which refers to reduced self-initiated cognitive, emotional, and behavioral activity, is also commonly reported among those living with a diagnosis of HIV. Treatment for depression in people with HIV infection involves cognitive behavioral therapy, and it is integrated with pharmacotherapy such as antidepressant and psychostimulant. So if depressive symptoms are very or severe and of sufficient duration, treatment with antidepressants may be initiated such as imipramine, or tofranil, disipramine or nopramine, and fluoxetine or Prozac. And if the patient um, may have may have psychostimulants such as methylphenidate or Ritalin, may be used in low doses if the patient has neuropsychiatric impairment. However, if for patients with severe depression who do not respond to pharmacologic interventions, electroconvulsive therapy may be necessary. For integumentary system, cutaneous manifestations are associated with HIV infection, and the accompanying opportunistic infections and malignancies, um, Kaposi sarcoma, which was described earlier, and opportunistic infections such as herpes zoster and herpes simplex are associated with painful vesicles that disrupt the skin integrity. So we have molluscum contagiosum, which is a viral infection characterized by deforming plaque formation. And we also have seborrheic dermatitis, which is associated with an indurated or diffuse scaly rash involving the scalp and the face of the patient. So for many patients treated with antibacterial agents such as trimethoprim, sulfamethoxazole or TMP as MZ develop a drug-related rash that is pruritic with pinkish red macules and papules. So patients with any of these rashes experience discomfort, have body image changes, and are increased risk for infection may due to disruptive skin integrity. So there will be generalized folliculitis associated with dry, flaking skin or atopic dermatitis such as eczema or psoriasis. For gynecologic manifestation, so there will be persistent recurrent vaginal candidiasis may be the first sign of HIV infection in women. So women with HIV are increased risk for developing pelvic inflammatory disease. So now let's proceed to nursing management. So this is very important for you to help your patient at least prolong their life. So, of course, you have to follow or you have to use your nursing process, wherein the first step is do your assessment. So, nursing assessment include identification of potential risk factors, including a history of risky sexual practices or IV or injection drug use. So it is important to assess the following: the nutritional status of the patient, the skin integrity by checking the skin of your client, of course, from head to toe, respiratory status, the neurologic status, the fluid and electrolytes balance. So for nutritional status, this can be assessed by obtaining a dietary history as what you have learned during your NTT or nutrition and diet therapy, and identifying factors that may interfere with oral intake such as anorexia, nausea, vomiting, oral pain, or difficulty swallowing. So for respiratory status, so it is assessed by monitoring the patient for cough, sputum production, for example, the amount and the color of phlegm. If there is shortness of breath, orthopnea, tachypnea, and even chest pain. So, for neurologic status, it is determined by assessing the level of consciousness. You can use your LOC or orientation to person, place, and time. And of course, you can check memory lapses. You can check the recent and the remote memory. So the mental status is assessed as early as possible to provide a baseline. So the patient is also assessed for sensory deficits such as visual changes, headache or numbness, and tingling in the extremities. Also, motor involvement such as altered gait, paresis or paralysis, and seizure activity. For fluid and electrolyte status, it is assessed by examining the skin and the mucous membrane for turgor and dryness. So, dehydration may be indicated by increased thirst, decreased urine output, postural hypotension, weak and rapid pulse, and even urine-specific gravity of 1.025 or more. So, electrolyte imbalances such as decreased serum sodium, potassium, calcium, magnesium, and chloride typically results from profuse diarrhea. The patient is, of course, assessed for signs and symptoms of electrolyte deficits, including decreased mental status, muscle twitching, muscle cramps, irregular pulse, nausea and vomiting, and shallow respirations. You can also count the respiratory rate of your patient. So the following are just sample nursing diagnoses, or these are just the list of potential nursing diagnoses. So we know that diagnosis for HIV is very comprehensive or complex because of the nature of the disease. So, however, based on the assessment data, major nursing diagnoses may include the following. Number one, impaired skin integrity related to cutaneous manifestations of HIV infection, exoscariation, and diarrhea. Another one is diarrhea related to enteric pathogens or HIV infection. Another one is risk for infection related to immune deficiency. Activity intolerance related to weakness, fatigue, malnutrition, impaired fluid and electrolyte balance, and hypoxia associated with pulmonary infections. So another nursing diagnosis are the following: chronic confusion related to cognitive changes associated with HIV encephalopathy, ineffective airway clearance related to infection, increased bronchial secretions, and decreased ability to cough related to weakness and fatigue. Another one is acute and chronic pain related to impaired perianal skin integrity secondary to diarrhea, Kaposi sarcoma, and peripheral neuropathy. So another sample diagnosis: imbalanced nutrition, less than body requirements related to decreased oral intake. Social isolation related to stigma of the disease, withdrawal of support system, isolation procedures, and fear of infecting others. Grieving related to changes in lifestyle and roles and unfavorable prognosis. Another one is deficient knowledge related to HIV infection, means of preventing HIV transmission, ART or antiretroviral therapy, and self-management strategies. Now, since we're done with the assessment and we already identify our nursing diagnosis, now let's proceed to the third steps of our nursing process. This is the planning and goals. So our plan and goals includes the following: maintenance of skin integrity, resumption of usual bowel patterns to address diarrhea, absence of infection, improved activity tolerance, and coherent thought processes. So our plans also include improved airway clearance, increased comfort, improved nutritional status, increased socialization, expression of grief, increased knowledge regarding disease prevention and self-care, and absence of complications. So now let us put our plan into action by doing our nursing interventions, which is the fourth steps of our nursing process. So this includes promoting skin integrity, This can be done by assessing routinely for changes in the appearance of the skin, the location, and the size of lesions if there is any, and evidence of infection and breakdown. You have to encourage the patient to maintain a balance between rest and mobility whenever possible. So, promote usual bowel patterns. So, you have to help your client, you have to instruct the client to, or you have to assess for diarrhea, and then you have to monitor the frequency and consistency of stools in the patient's reports of abdominal pain or cramping associated with movement. You also need to check the quantity, the volume of liquid stools. You have to measure it as part of your intake and output. And then another intervention is preventing infection. To prevent infection, the patient and the caregivers are instructed to monitor for signs and symptoms of infection such as fever, chills, night sweats, cough, with or without sputum. If there is a shortness of breath, difficulty breathing, oral pain, and difficulty swallowing. So another part of our intervention is improving activity tolerance. So you have to monitor the patient's ability to ambulate and perform activities of daily living. So you may need to apply what you have learned during your DFN, the theory of self-care. So patients may be unable to maintain their usual levels of activity because of weakness, fatigue, shortness of breath, and etc. So, so assistance in planning daily routines that maintain a balance between activity and rest may be necessary. For maintaining coherent thought processes, the patient is assessed for alterations in mental status that may be related to neurologic involvement, metabolic abnormalities, infections, side effects of treatment, and coping mechanisms. So, if your patient experiences altered mental or cognitive status, the family and support network members are instructed to speak to the patient in simple, clear language and give the patient sufficient time to respond to your question. It is also important to reorient your patient to surroundings and location. Okay. So for improving airway clearance, so respiratory status including the rate, the rhythm, the use of accessory muscle and breath sounds, as well as mental status and skin color must be assessed daily. So if there is any cough and quantity and the characteristics of the sputum must be documented. So pulmonary therapy such as coughing, deep breathing, postural drainage, percussion, and vibration is provided as often as every 2 hours to prevent stasis of secretions and to promote airway clearance. So it is also important to place your patient in high Fowler position or semi-Fowler position that facilitates breathing and airway clearance. Adequate rest is also essential to minimize energy expenditure and prevent excessive fatigue. So, to continue with our nursing intervention, so another important nursing intervention is to help our client relieve the pain and discomfort. So, you have to assess for the quality and the severity of pain associated with impaired perianal skin integrity, so the lesions of Kaposi sarcoma and peripheral neuropathy. So the effects of pain on elimination, nutrition, sleep, affect, and communication are explored along with relieving factors. So improving nutritional status is also important. This can be assessed by monitoring the weight or computing the BMI of your client, monitoring the dietary intake and serum albumin or BUN, protein, and transferrin levels. So you also need to assess the patient for factors that interfere with oral intake such as anorexia oral and esophageal candidiasis, infection, nausea, pain, weakness, fatigue, and lactose intolerance. So we also need to help the client decrease the sense of isolation. So we know that people with AIDS are at risk for double stigmatization. They have what the society refers to as a dreaded disease, and they may have lifestyle that differs from what is considered acceptable by many people. So it is really important to be there with your client and to assess your client. And then coping with grief. So as a nurse, you can help the patient verbalize their feelings and explore and identify resources for support and mechanisms for coping, especially when the patient is grieving or anticipated losses. So the patient is encouraged to maintain contact with the family, friends, co-workers, and to use local or national AIDS support groups and hotlines. So in improving knowledge of HIV, so the patient and the family are educated about HIV infection, the means of preventing HIV infection, the use of ART or antiretroviral therapy, and the appropriate self-care measures. So information about the purpose of the medication, their correct administration, the side effects, and the strategies to manage or prevent side effects is also provided. So you need to instruct your patient to avoid others with active infections such as upper respiratory infections because again, patient with HIV has a very low immune system function. So nurses also need to help in efforts to prevent HIV infection by educating how to eliminate or to reduce risk associated with HIV infection and AIDS. So HIV is transmitted through the exchange of some infected body fluids such as seminal fluids, vaginal fluids, which is transmitted during sexual intercourse. So it is important to give your patient an education about the use of condoms, the proper use of condoms, which are highly effective in reducing the transmission of HIV. So the HIV negative person must be motivated and have the freedom to choose to use the method. So the patient may use pre-exposure prophylaxis. So pre-exposure prophylaxis involves taking one pill containing 2 HIV medication, such as tenofovir, disoproxil fumarate 300 milligrams, and M3C tabine 200 milligrams or Truvada daily in order to avoid the risk of sexual HIV acquisition in adults and adolescents aged 12 and older. So the behavioral interventions have been effective in reducing the risk of acquiring or transmitting HIV by ensuring that the people have the information, motivation, and skills necessary to reduce their risk. HIV testing also is important because most people change behaviors to protect their partners if they know they are infected with HIV. And the third one is linkage to treatment and care, which enables individuals with HIV to live longer, healthier lives, and reduce their risk of transmission. So, for health promotion, we can help our patient protect against HIV infection by giving the following information. So, abstain from exchanging sexual fluids such as semen and vaginal fluid. Reduce the number of sexual partners to one, so you have to be loyal. Always use latex condoms. If the patient is allergic to latex, non-latex condoms should be used. However, they will not protect against HIV infection. So, not Do not reuse condoms. Baka i-wash nyo lang yan. Avoid using cervical cups or diaphragms without using a condom as well. Always use dental dams for oral, genital, or anal stimulation. So it is important to avoid having unprotected sex with another HIV seropositive person. Cross-infection with that person's HIV can increase the severity of infection. Do not donate blood, plasma, body organs, or sperm if you are infected with HIV. So consider pre-exposure prophylaxis if regularly engaged in high-risk behaviors. The patients who are HIV seropositive should also be advised to take the antiretroviral regularly to achieve viral suppression and inform previous, present, and prospective sexual and drug-using partners of their HIV-positive status. If the patient is concerned for their safety, advise the patient that many states have established mechanisms through the public health department in which professionals are available to notify exposed contacts. Avoid anal intercourse because this practice may injure the tissues. If not possible, use lubricant. There are water and silicone-based products designed for anal sex. Avoid manual anal intercourse or fisting. Avoid sharing needles, razors, toothbrushes, sex toys, or blood-contaminated articles. So, after intervention, of course, is the last step of our nursing process. We have the evaluation. So, those are the expected patient outcomes. One is maintains skin integrity, resumes usual bowel habits, experiences no infections, maintains adequate level of activity tolerance, maintains usual thought processes, and maintains effective airway clearance. So to continue with our expected patient outcomes, the patient experiences increased sense of comfort and less pain, maintains adequate nutritional status, experiences decreased sense of social isolation, progresses through grieving process, reports increased understanding of AIDS, prevention of HIV transmission and ART, and participates in self-management strategies as possible, and of course remains free of complications. So that concludes our presentation. So this is the references of this presentation. Thank you everyone. I hope you learned a lot about our topic on HIV. God bless!